Whipple disease is a rare systemic infection that can quietly begin with joint symptoms and eventually affect the intestine, brain, heart, and other organs. Our case is a 45-year-old man who initially appeared healthy, but gradually developed a collection of symptoms that would eventually reveal a rare infectious disease. His first major complaint was intermittent joint pain, particularly involving the knees and ankles.
An important clue was that the joint pain was migratory. The discomfort seemed to move from one joint to another, rather than remaining fixed in a single location.
In Whipple disease, joint symptoms can appear months or even years before the classic intestinal symptoms, making the diagnosis surprisingly difficult.
Because joint pain is common, the initial presentation can resemble an ordinary inflammatory arthritis. This may delay recognition of the underlying infection.
Several months later, the clinical picture changed. Gastrointestinal symptoms began to appear. He developed persistent diarrhea that continued over many weeks. This was no longer an isolated gastrointestinal episode. It was becoming chronic. Along with diarrhea, he experienced abdominal discomfort and progressive digestive disturbance. Despite continuing to eat, he began losing weight. Progressive weight loss suggested that nutrients were not being properly absorbed. Fatigue and weakness gradually developed, reflecting the consequences of chronic illness and nutritional deficiency. When nutrients are not absorbed properly, the body receives less energy and fewer essential nutrients. Over time, this can cause weight loss, weakness, and malnutrition. To understand Whipple disease, we first need to understand the organ most commonly associated with its classic presentation, the small intestine. Healthy intestinal villi dramatically increase the surface area available for nutrient absorption. Digested nutrients cross the intestinal lining and enter the circulation, providing energy and essential building blocks for the body. Whipple disease is caused by an unusual bacterium called Trophorema whipplei. Trophorema whipplei is a gram-positive actinomycete, capable of surviving within host macrophages. In susceptible individuals, the organism can reach intestinal tissues and interact with immune cells within the mucosa. Macrophages normally engulf and destroy invading microorganisms. In Whipple disease, however, the organism can persist within these cells. Instead of being completely eliminated, Trophorema whipplei can accumulate inside macrophages. Large numbers of infected macrophages accumulate within the lamina propria, producing the characteristic microscopic appearance of Whipple disease. Compare the healthy intestine with the diseased intestine. The normal villi are slender and organized, while the affected mucosa becomes thickened and distorted. The accumulation of infected macrophages changes the architecture of the intestinal mucosa and interferes with normal absorptive function. As intestinal architecture and function become impaired, nutrient absorption decreases. This process is called malabsorption. Poor absorption of nutrients, including fats, can contribute to steatorrhea, fat-rich stools that occur when dietary fat is inadequately absorbed.
Chronic malabsorption can lead to deficiencies of iron, folate, protein, and other essential nutrients.
Nutritional deficiencies can contribute to anemia, adding to the patient's fatigue and weakness. Protein malabsorption and chronic intestinal disease may also contribute to low serum albumin and worsening nutritional status. On examination, the patient appears thin and malnourished, with pallor and abdominal discomfort. Additional findings may include lymphadenopathy or other signs of systemic disease. Laboratory testing may reveal anemia, low albumin, and biochemical evidence of nutritional deficiencies.
Stool examination can demonstrate evidence of malabsorption, including increased fecal fat in patients with steatorrhea.
Upper gastrointestinal endoscopy may reveal pale yellow or yellowish, thickened and abnormal small intestinal mucosa. The crucial next step is obtaining a small intestinal biopsy for histopathological examination. Under the microscope, the intestinal villi contain numerous foamy macrophages within the lamina propria. The classic diagnostic clue is the presence of PAS-positive material within these macrophages. Large foamy macrophages containing PAS-positive, diastase-resistant material in the intestinal lamina propria are a classic finding in Whipple disease. This finding strongly suggests Whipple disease. Although additional testing is important to establish the diagnosis and distinguish it from other infections. Molecular testing can detect Tropharima Whipple DNA by polymerase chain reaction, providing important confirmation of the diagnosis. Celiac disease is an important differential diagnosis because it also causes malabsorption and villus abnormalities. Histology and microbiological testing help distinguish the two. Giardiasis can also cause chronic diarrhea and malabsorption, but the organism and microscopic appearance are distinctly different.
Mycobacterium avium complex can produce macrophage-rich intestinal lesions, particularly in immunocompromised patients, making microbiological differentiation essential.
Whipple disease is not limited to the intestine. Tropharima Whipple can disseminate and involve multiple organs. Neurological involvement can produce serious manifestations, including cognitive changes, abnormal eye movements, myoclonus, and ataxia. The heart may also be involved. Whipple disease is an important cause of culture-negative endocarditis. Lymph nodes, joints, eyes, and other tissues may also become involved, demonstrating why Whipple disease is considered a systemic infection. The complete pathway can now be understood. Infection with trotrasecular persistent involvement, malabsorption, and possible systemic dissemination. Whipple disease requires prolonged antibiotic treatment. Therapy must be carefully selected, involvement is present. With appropriate treatment, clinical improvement can be dramatic. Remember the classic pattern: a middle-aged man, migratory arthralgia, chronic diarrhea, weight loss, and malabsorption. Think Whipple disease. Recognizing the pattern is the first step.